clarity there? Not this, it is this.
Hello, madam.
Yes.
What is her LMP? What is the day of her cycle?
I don't know.
Anyone know?
So there is already flow in the 10th day of the cycle still. But remember one thing, the day of the cycle is not at all important. What is important is its synchrony with the follicle. If whatever the day of the cycle, if the follicle has grown only, then the endometrium is going to grow. There is no relationship between the day of the cycle. In the PCO patients, we have seen that even in the natural course, they would have a pregnancy, even if they are getting periods at 45 days or 60 days. Do you think they ovulate on 14th day? They don't, right? So, and in no physiology book is the length of the proliferative phase fixed. The length of the proliferative phase is not fixed. It is only the length of the secretory phase which is fixed. So proliferative phase can be any long. Now doesn't matter. What is important is whether the follicular growth correlates with the endometrial growth or not. And in this case where you said the endometrium, you only said, right? Who said? I think it was Dr. You said? The last time the endometrium was thin? Yes, so
Yes, I
if you
said
see that the follicle has grown to beyond 18, and it also shows flows, and still the endometrium is not growing, only then it should be of a concern, because here you can see that even with that thin endometrium, you have started seeing the flows in the endometrium already. That means that the endometrium is thick, is growing, and anything more than 6 should be fine. So 5 millimeters on day 30, but day doesn't matter. As I told you again, look at the follicle. The follicle grows beyond 18 and shows good flows, and still the endometrium is not there. Only then it is a concern. Most likely here, if you wait for either a good quality follicle, or you develop a instead of a monofollicular or bifollicular development, you will get a good endometrium. Endometrium otherwise looks very healthy in this. We will discuss that with the presentation, but yes, if it is an IUI cycle, only the dominant follicle. If it's an IVF cycle, you need to measure all the follicles. But again, what is dominant follicle is also that requires more explanation. Can somebody please tell me the history of this patient? Hello? Can anybody please tell me the history of this patient?
গ্রুপ সির পার্টিসিপেন্টদের নাম ঘোষণা করা হচ্ছে, ওরা ওই রুমে যাবে, হ্যান্ডসনে যাবে হচ্ছে 11টা।
So basically she is a primary infertility patient,
ডক্টর আইনুন নাহার হামিদ,
primary infertility patient with irregular menstrual cycles. Menstrual cycles are regular only with medicines. If they are regular with medicines, that means we only consider it as irregular, otherwise that means she is only getting withdrawal bleeds. Okay, we are starting with the scan,
মিল্লাতুন নাহার Irene,
and we have uterus, which probably is retroverted retroflexed. Again, I'm not seeing any uterus in the midline. Spanning the probe onto the right side, the uterus is right onto the right side. It is absolutely towards the right side. Beta relax karo, relax karo. And you are there also seeing only one cornu. Let me move on to the other side. Yeah, look at that. Probably 1 and 2. So it's probably not even a bicornuate, it's a didelphys. So, and in both the endometrium, in both the horns, the endometrium is superb. I'm going to turn transverse, and on the transverse section we are going towards the cervix, and now we are going towards the fundus. And you should be able to see 2 cavities at a time, but it is too widely spread. One is here, and probably the other one is right here. See? Yeah, this is one and this is the another one. Yes? Had it been a 3D, I would have been able to show you this very beautifully, very beautifully. Anyway, so we have a good endometrium. So this is one horn. I repeat, this is the another horn on the left side. That was on the right side. This is on the left side. You're seeing beautifully the endometrium here. The endometrium appears very, very nice and good. It is mostly not, let's see what is the situation of the cervix, but it is surely diadelphys. It is surely diadelphys. It is not, or it is a complete bicornuate with bicollis. We will see the cervix. We will see the cervix. Let us first trace the ovaries. See, the ovary is placed right behind, but there is something large and cystic there, which I probably don't like much. Maybe a bowel, but it looks more like a hydrosalpinx. But I'm not sure. Let us confirm. Focus. I've changed the focal zone. You're seeing the ovary, which has multiple follicles. There is a large calcified area in the ovary, or hyperechoic area in the ovary. No, I don't think there is any hydrosalpinx. It was only a poor visibility which told us that. If I'm doing in and out movements, see, the ovary is sliding on the uterus, right? So it is not fixed. So that ovary looks normal. Going on to the opposite side now, and this is the left cornu of the uterus now, and we should be able to see the ovary by the side of that. We are seeing the ovary right there. Yes, and that ovary also looks normal because there are multiple follicles. Therefore, in spite of no mature follicle, you are still seeing a nice thick endometrium. Yeah? This is, of course, I cannot say anything at this point of time because PCO diagnosis should be made only on day 2 or 3 of the cycle. But the way I am seeing multiple follicles and the way I am seeing hyperechogenicity of the stroma, it is mostly a PCO patient. This is a PCO patient. So it is, and it is a divided, see, now you can actually see the 2 uterine cavities. You're seeing one, I mean the uterus myometrium, one here, one there, and then we are moving, trying to move towards the cervix. As we are moving towards the cervix, beta thoda नीचा रख सकते हो आप. Please ऊपर मत खींचो. No, don't pull the legs there. Let them be a little. No. Bus. So let's come out first, and now let us follow the cervix. This is one. This is second, probably. Now I'm in the transverse plane. And trying to go towards the cervix. And it actually looks like 2 cervices, but I'm sorry, the visibility is truly poor. Partially because of the patient's position. बेटा थोड़ा कमर रिलैक्स करो प्लीज. हाँ करो रिलैक्स करो. नहीं ऊपर मत जाओ. हाँ थोड़ा ऊपर हटो, थोड़ा ऊपर हटो, इतना. हाँ थोड़ा सा, बस. You ideally will see 2 cervices very clearly, but unfortunately I don't know whether it's patient. I mean पूरा position उसका. बेटा थोड़ा lift होके इधर देखो. She's absolutely on one side. Oh, she's moving. She's turning around. Just bring her in the center. No. इतना चौड़ा पैर भी मत करो. इधर रखो और वो भी इधर रखो. हाँ. So you can see that if the position of the patient is not right, you can have a lot of difficulty. I'm sorry, but I can really not appreciate in this whether there are 2 cervices or not. This is one for sure, which is on the left side. On the right side, I am not able to trace the cervix. This is the right cornu. This is the left. So I'm not able to trace it. I do not know it is two cervices or it is single cervix. You would need a 3D for that for sure, and maybe a little better adjustment of the patient position also, so that we can trace the cervix right up to up. So, but it is definitely not a unicorn. I mean a unicornuate with a rudimentary horn, because had it been a rudimentary horn, and if it had been non-communicating, then she would have a severe pain. So and both the horns are almost equal, so we would not say it's a rudimentary horn at all. So it is either bicornuate bicollis or it is a diadelphys for sure. I don't want. I'm fine. Don't worry. I'm fine. Don't worry. Don't worry. I'm fine. Nothing. Just go to your preset once. Preset. TBS. No, I'm not happy with the position of the patient. थोड़ा नीचे आओ बेटा. बस पैर लंबा मत करो, हाँ, बस 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 बस. आओ, थोड़ा आओ. हाँ, और ना थोड़ा सुनो, थोड़ा ना इधर से मेरी तरफ. Yes, you can, but for that you need to do a scan, a perineal scan, not a vaginal scan. You can do a vaginal scan also, but it is always better on a perineal scan, and you do it with Valsalva. Of course, always. You always have to do a day 2 or a 3 scan, and that is something very important to decide what to give as a stimulation protocol, and whether also if you want to decide whether patient is PCO or not, you definitely require to do a day 2 or a 3 scan. Even the guidelines say that diagnosis of PCO on ultrasound can be only made on day 2 or day 3. Okay. Why don't you talk on the mic? They have another mic so that they will understand. So she had a fibroid, she has a history of myomectomy, and apart from that, okay. Okay. So just before I forget, let me tell them. So there was a mid-trimester abortion, and at that time it was diagnosed that it is probably because of fibroid, and therefore a myomectomy was done, which was posterior wall intramural fibroid. Okay. And after that there is a secondary infertility. Okay, urethra, bladder, symphysis pubis, bladder, rectum. Uterus again not in the midline. The endometrium is just superb. The cervix, the glands have started becoming hyperechoic. They are not completely hyperechoic. Let us move, bring the uterus in the center. There is mild adenomyosis, posterior wall. Then the uterus, the endometrium does look quite good. Yeah. I am going to first decrease this. I also am trying to okay, so it is always taken in the mid-sagittal plane. So let us first shift to the mid-sagittal plane, and then we will bring the uterus in the center and body in the center, and that is when we can measure the endometrial thickness. If there is any polyp or anything in the endometrium, it is considered as a part of the endometrium, and the thickness is measured along with the polyp. But if it is a fibroid, it is considered outside the uterus. See, you are seeing a lot of adenomyosis here. There is a lot of adenomyosis anteriorly also. It is posteriorly also there. Transverse section going to the we have not, on the first view it is not looked like a fibroid, but it might be a fibroid. I mean, we'll check. We have not checked yet. So the size of that follicle, so it comes to 24 plus, so that if at all we have to give a trigger, that is a last time. There is another follicle also. This is also close to 23, 22, 22.5, 20, 21.5. I do agree that the color pickup could have been much better than this, but at least we are seeing.
Hello, madam. One quick question, please.
Yes.
Madam, how to measure perifollicular blood flow?
That is what I'm
PSV?
doing. That is what I'm doing.
And at the midline, that patient,
Huh.
this polyp may hamper to the embryo transfer.
No, madam, it will not come in the way.
Yeah, no need to go for the any
Nothing to be done.
hysteroscopic evaluation.
Nothing to be done for her.
Okay, okay, and also another question is there. I have
Because I put the flow and there was a single feeder vessel, nothing else there, so nothing to do for that.
Okay, okay. And another one is the in case of IUI, if there is follicle matures even 21 days or 22 days, I have seen your
Even
center.
if it is 40th day, I will not mind.
Okay, and trigger, I have also the 19-day trigger was given, and that patient was pregnant by IUI.
Yes.
So I know that. Okay, thank you.
The bladder is full. The bladder is full, and there will be difficulty in seeing the scan, but if we can see it, we will do it, otherwise we will send her, okay? So here beautifully the right ovary is seen. I'm going to decrease the scanning angle. I'm going to change the depth, and if I'm going to press a little, I'm seeing multiple follicles there. We need to count the antral follicles for the baseline scan. I'm going to move right out of the ovary and then come back in the same direction. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, at least 14 follicles. So that is truly a good reserve. Then we will switch on the Doppler, and I don't know how well we will be able to see the Doppler, but anyway, before that, let us measure the ovarian volume.
Oh, data can be important na.
So the longest diameter, the longest perpendicular, it's gone. The longest diameter perpendicular to the long diameter and the third diameter. So that gives us, oh no, do you have a volume? Can I do a volume? Once again, volume. Yeah. So I'm sorry, we will have to do it again because I didn't press volume. So that gives me a volume of 3.7. So the volume is not that big, but we need to document this because we want to do the baseline scoring. We have the ovary there once again, and I'm going to switch on the Doppler. Hopefully we can see some flows in there. We are seeing the main hilar vessel. So you are seeing a vessel which is seen in its long axis. Yes, and if you trace it out, you can trace it outside the ovary. Hopefully we can. Yes, see, you are seeing the entire vessel going out of the ovary, which means it is a feeder vessel. It means it's a hilar vessel. It is either the ovarian artery or it is the ovarian branch of the uterine artery. That plane, we call it a hilar plane. From there, we are going to move away, losing the hilar plane and still being able to see the vessels in the stroma. Hold your breath, hold your breath, hold your breath, hold your breath. Don't move, don't move, don't move, don't move, don't move. Yes, so that is the ovarian stromal flow that you measure, and we want velocity trace upper, not lower, trace upper. Not from there, not from there. And you are tracing the lower. I want the upper. No, not from there, my dear. Trace it from here till here, and see, it is not going till up there. You have a sensitivity on this. Should be okay. Not perfect, but should be okay. Just fix it. Oh yes. So the RI is 0.5. And the PSV, which is important to us, the PSV is 8.8. Sorry, it is 12.5. So those are the parameters which need to be taken into consideration going on from the uterus. Now we are seeing the uterus there. Just remove this. Okay. We are seeing the uterus. We are seeing the uterus. The uterus doesn't seem to be very good. It looks like not only adenomyotic, but there is probably also the thin endometrium that you are seeing. Listen, if you are seeing the endometrium like this, you don't see the morphology well. If you lift the uterus up, you will see the endometrium better. It is a thin single line endometrium, but you can see it better when you lift the uterus. You go on to the transverse section and you move to the opposite ovary. Check the parameters as we did for the first ovary, for the second ovary also. We can just fix it right now and we can do the measurements later on if we want to save some time. You can measure the ovarian size there again, measurement and volume, and So that volume comes to 4.5, and we will count the number of follicles there. I hope we can see it good. दुखता है, दुखता है. Please relax करो थोड़ा सा. बोलो उसको relax करे थोड़ा सा. Can somebody press here? Can somebody press here? Yes, so that makes it a little better. 1, 2, 3, 4, 5, 6, 7, 8, 9 here. And then putting on the flows there. Can I? You are again seeing the hilar flow, and then we will move to the stroma. So you can document that flow also. Please measure. And so these are the ovarian measurements for the ovarian for the baseline score. .46 and PSV is no, it's not 13.5. V max 1, A is average. Okay. Okay. So that is the ovarian right ovarian left ovarian measurement. We earlier did the right ovarian measurement, and we have already done the uterine assessment. So that completes the baseline scan, and that will help us decide what should be her stimulation dose. It is all, hilar vessel is not a stromal vessel. It is not a parahilar vessel also. From the hilar plane you have to move away so that you lose the vision of the hilar vessel, and then whatever small vessels that you find in the stroma is what you are going to measure the flow in. Okay? If all the follicles, if they are appearing less than 10 millimeters or 9 millimeters, you don't need to truly measure them, unless they look very small and they are smaller than 7 millimeters. How many patients still? Come. No, so otherwise we will not be able to do lectures. I don't mind doing this, but we will not be able to do. Yeah, so if at all your patients have to be done, in the sense they are waiting for a scan, we can do it in the lunch time. Okay, I will do all the patients for you in the lunch time, but we need to start lectures, otherwise we will not be able to finish it. No, that is okay. I just need water. Water is here. No, I need water. That is it. Just go to your preset once. Just move this and let me go in. Sorry, loudly. So this is a case of stage 4 endometriosis operated, tubal patency re-established. Yes, and what else did you say? Does she have pain still? Endometriosis pain, does she have still? She has pain for endometriosis still? पूछो दुखता है उसको? So she has dyspareunia and dysmenorrhea both? I'm following the The bowel. बेटा ढीला रखो, ढीला रखो, ढीला रखो बेटा. So we are following this line. It is the anterior muscularis of the rectum. And here. Yes. ये दुखता है पूछो उसको. ये दुखता है पूछो. ये दुखता है पूछो. Slight pain, not much. Okay. Yes, this is where you're seeing a large patch, and see it is painful. Just ask her. Yeah? Yes, so this is where you're seeing that this hypoechoic line, it has suddenly broadened. There is a large ill-defined hypoechoic area here, which this line, this is a hypoechoic area here. It is painful on probe pressure. You are seeing finger-like extensions with peripheral hyperechogenicity, and see, it's a large patch. It's a very large patch, in fact, of endometriosis, and you are moving towards the other side still further, and it is then gradually getting normal. You are moving here, and yes, so this is a large patch of endometriosis still inside. It's a huge endometriosis. It is in the bowel, on the bowel. It is on the bowel, so it's posterior compartment. And then as we move up, you're still seeing some extension towards here, still moving ahead, and we are now close to sigmoid. Let's move out. The bladder again is full here, but let us see if we can see the uterus. Yes, we can see the uterus, but the uterus appears to be completely displaced. If we can just re-evaluate her after empty bladder. Let's see if we can see everything. It's fine. Adenomyosis more in the anterior wall as compared to the posterior wall. Yes, but the endometrium more anterior than posterior. Endometrium looks quite okay. The fundus is fine, but there is free fluid going posteriorly. Cervix, that is fixed. As rightly mentioned, no, this is not pouch of Douglas. The pouch of Douglas is here. So it's been already mentioned that the pouch of Douglas was obliterated, but it is probably even post-operatively, it's again reobliterated. We will check it again. This is the ovary posteriorly, and ovary has a large endometrioma again, see? Yes, or maybe a corpus luteum, but what day of the cycle you said?
Hello?
Yes, ma'am.
Madam, can you see the whether the rectovaginal septum is involved?
Yeah, I'm going to do it, ma'am. I'm going to do it. After I finish this, I'm going to do it. Today is day 18, so this might be a corpus luteum in that stage, in that case. Was she on ovulation induction? No, it's a natural cycle. And what is her cycle length? And see, this is a low resistance flow that you are seeing here. It is not actually this much flow. If your setting is good, you may see much more flow. You will actually see a beautiful ring of color there. But anyway, whatever flow we are seeing, we will be satisfied with for the while. No, this is venous. No, this is also venous. Yeah, you actually see so beautiful ring of color, and it is not difficult. And this is all coming as venous flow only. But there should be a nice arterial flow actually. Yes, see, just wait, don't touch. Don't touch, please don't touch. Yeah, so that is where you are getting the arterial flow. Of course, it's moved again. It is not too difficult usually. There are lots of adhesions. It may be post-operative, it may be because of endometriosis also. No, it is not because of that. It's because of the movement. Beta, can you please ask her to hold her breath, not to move. Please don't move. See, there. So you can measure it. So that is a low resistance flow. No, that is not a correct RI. RI can never be more than 1. RI as a rule can never be more than 1. Yeah, that is what I was telling you since long. I want manual trace. I was telling you. No, it's not that low. Let me measure it. Should I start? Where do I start from? Okay. So what do I press here? Update. But it is going up. So it is here. Update. Yes, so it is a low resistance flow, 0.54, right? So that is what is it. So it's a nice low resistance. So it's a corpus luteal flow there. The endometrium is secretory but is not thickening, because you can see that the endomyo junction is very, very irregular. You can observe here. It's very, very irregular. It's thick and irregular. Okay? And then if you go on to the opposite side, this ovary also has something which may be an endometrioma, which may be a corpus luteum, but this looks more like an endometrioma because it doesn't have that much flow, or it may be an inadequate corpus luteum. To confirm, you have to look for its persistence. If it persists into the next cycle, remains same in size, that means, or it increases, that means it is an endometrioma. Otherwise, and then again pain on probe pressure. Pucho usko ye dukhta hai? No, so that is more likely to be an inadequate corpus luteum. So that's how you are going to do it. And then madam wanted to see the rectovaginal septum. So I'm going to pull out the probe once again, and we are going to start the entry of the probe. And then when I say rectovaginal septum, remember that it is only that part of the bowel and the part of the vagina where, if you can see here, it is the rectum and the vagina which are close opposition to each other. The moment you move in and the rectum moves posteriorly, the anorectal flexure, that is when you look, I mean, beyond that it is not a rectovaginal septum. So rectovaginal septum is only the small area. Yes, I know that most of the times all the posterior compartment involvement is written as rectovaginal, but that is not rectovaginal septum. Okay, only if there is endometriosis that you see in this area. If you the lesion that you saw earlier, if you see it in this part of the bowel, then only it is a rectovaginal septum involvement. Okay, so here it's not a rectovaginal septum involvement that moves quite freely. Let us try and look at the. So if I'm going now, I'm going extreme posteriorly, and I'm looking at the posterior vaginal wall. This is the peritoneum overlying. I'm going deeper, and as I'm going deeper, now I'm deep into the posterior fornix. So it has been quite reconstructed, and now this is the uterosacral ligament on the right side, and if I'm moving on the left side, this is the uterosacral ligament onto the left side. So the uterosacral ligament also is not involved. Rectovaginal septum is not involved. There is a large bowel endometriosis, There is a corpus luteum in the left ovary, but the left ovary is still adherent to the uterus. The right ovary does show a lesion which may be query endometrioma, query inadequate corpus luteum. You do a follow-up and you will know that if it persists, it is an endometrioma. If it doesn't, it is a corpus luteum. And there is adenomyosis of the uterus. So these are the findings. Okay, we to do this as the last one and then we go to the lectures. Yeah, so that's what I am not going to take. Yeah, we'll do it later on. Fine, perfect. So let's go to the lectures. Do you have a sanitizer or something? After sanitizer. Thank you. We are not doing anything for her. Unless you check because it was grade 4 and because she's already been operated, you should not trust the tube-ovarian relationship, though the tubes may be patent. And otherwise also, if you go with the guidelines for grade 3 and grade 4 endometriosis, IVF is the line of treatment. profile of that that person. Similarly, for the follicle and the endometrium, it is essential to follow the follicle right from the time the dominance of the follicle is selected, and we know that the dominance of the follicle is usually selected at about day 5 in a normal length cycle. The older study says that you can assess the dominance or you can document the dominance on ultrasound on about day 7. But I probably don't believe this with all the new very high quality ultrasound scanners. The day the dominance is selected, we can definitely evaluate, we can definitely document it. But what is dominance is something very important to understand. Dominance isn't just any organ or a structure would get sensitized to that biochemical or that hormone only when it is exposed to that biochemical. That means that if the FSH receptors have to develop in the follicle, FSH has to reach the follicle, and only then the receptors will develop, and only then the dominance is selected. That means that if I want to truly confirm the dominance of the follicle, I must be able to see the blood flows. I think this is not consistent. Hello? Now it is okay, but it has to remain steady, okay? So what is important is that you should be able to see the you should be able to see the flow of the follicle. Now if you say if you know that, I mean, if therefore whenever you see a follicle which has reached 8, 9, 10 millimeters, it is very essential that you would switch on the Doppler. And see, many times it happens that you are doing a day 2, 3, 4, 5 scan. You will see a follicle which appears like 10, 11, 12 millimeters in size, and there may be 2, 3, 4 such follicles. So you are most of the times confused. There is multifollicular development, and many of you may also be thinking that this patient should not be taken for IUI. Let us take her for IVF. It is very important to understand that the follicle, as soon as it achieves its dominance, it is going to show you flow surrounding the follicle. And if you want to see it like, see this follicle which appears quite large, but it does not show any flow. If you say this is perifollicular flow, I don't agree with you, because remember, only the blood vessels which overlap on the follicular wall are perifollicular flow. The rest is not. So this follicle to me has no flow at all. This is another follicle by the side of it, but that also has hardly any flow. Say, even if you say it is just a bit of it which is touching that follicle, not really. Come in between now, just leave it. So that is also not a mature follicle, but if you go ahead, that is when you are seeing 1/3 follicle, and look, the entire hilar flow is being directed towards that follicle. Can you see that? And it shows a beautiful ring of color surrounding, which tells you, yes, this is definitely a dominant follicle. And this is one special mechanism by which the human physiology, normal human physiology of a single pregnancy is being maintained, because this flow, the entire flow, because it is directed towards one single follicle, therefore the follicles which are in the close vicinity of this follicle also stop growing, they regress, and therefore only single follicular maturation and single pregnancy is a normal physiology in a human being. That means we know that follicle which has reached 9 millimeters in size, beyond that you are going to check the blood flows, and only if the blood flows are present, only then the follicle is a dominant follicle. And if the follicle is a dominant follicle, because it has already developed sensitivity to FSH, it is going to grow at a rate of 2 millimeters, about 2 millimeters a day. There are different studies, they say 2 to 3 millimeters. There's one study which also says 1 to 4 millimeters, but usually 2 to 3 millimeters, even 3 millimeters is a little too much for the growth of the follicle. And then we all know that when the follicle reaches about 18 to 24 millimeter in size, that's when it's going to ovulate. If therefore I am doing a monitoring and I'm asked as to how often, the patient asks me how often do I have to come for my scans. This is often a question, especially for the working ladies. And then the schedule goes this way. If you are doing an IUI cycle, and if it is a oral ovulogen cycle, that means you are going to give only CC or you are going to give letrozole only, then you can call the patient for the first time only when it is the last dose of oral ovulogen. So if you are going to give CC, usually we give CC from day 5, 6, 7, 8, 9. And if it is letrozole, we would prefer to give it day 3, 4, 5, 6, 7. So with letrozole cycle, the first visit will be day 7. With the CC cycle, the first visit will be day 9. On that day when you do a scan, if all the follicles are still smaller than 10 millimeters and there is no dominant follicle, that does not mean that patient has not responded. The dose that you have given is going to act and the patient may develop follicle a little later. And if there is no dominant follicle, call her directly after 5 days. But if there is already a dominant follicle, calculate when you expect the follicle to reach 18-19 millimeters in size and accordingly call the patient. Say for example, today is the last day of oral ovulogen. I see the size of the follicle is 13, tomorrow 15, day after 17, day after then 19, that's when I'll call the patient. You understand? So that's how the oral ovulogen cycle monitoring is done. But whether it is oral ovulogen cycle or it is a gonadotrophin cycle, once the follicle reaches a size of 18-19 millimeters, beyond that you are going to call the patient every day to check the flows till you get optimum parameters to give a trigger. If it is a gonadotrophin cycle, and the best stimulation protocol would be when you can, for IUI would be letrozole plus gonadotrophin. Of course, gonadotrophin alone also gives excellent results, but when you give letrozole plus gonadotrophin, that is when you can cut down the cost of gonadotrophin and still not compromise with the results. Remember that when you give CC with gonadotrophins, the advantage of gonadotrophins is gone. Why? Because when you give CC, the LH is already high, and after that if you are going to add FSH, the ill effect of LH is still going to be there. And therefore, the results will be just as good as CC. But if you give letrozole plus gonadotrophin, the results would be as good as only gonadotrophins. So that is how letrozole plus gonadotrophin is one of the best protocols, or you can give only gonadotrophins also. But if you are doing a gonadotrophin IUI cycle, the first scan is done on the day when you give the first gonadotrophin. When you give the first gonadotrophin, on that day, if all the follicles are still smaller than 10 millimeters, directly call them after 5 days. But if there is already a dominant follicle, as told earlier, calculate when the follicle is likely to reach 18-19 millimeters and accordingly call the patient. Yes, we're clear about the number of visits. Now, going to measuring the size of the follicle, since I've already shown you on the live, longest diameter perpendicular to the long diameter, and the transverse diameter is the widest diameter parallel to the x-axis, and the mean of that is your mean follicular diameter. Remember, there is no point giving follicular size as 2 diameters. I'm writing 14 by 16, 12 by 15, doesn't make any sense to me. Why? Because it depends on the third diameter what would be the actual size of the follicle. Say for example, I'm seeing 14 by 16, 14 by 16 by 20 is a different size, 14 by 16 by 12 is a different size. So it is very important that you write all the 3 diameters and the mean of that. That is the correct size of the follicle. But if the follicle is not oval, it is absolutely spherical, then so you rotate the probe and still it is the same shape. That is when you can take only one diameter, and that diameter is an AP diameter and not a side to side diameter. Okay? Why? Because from these 2 walls the sound beam reflects completely, so these 2 margins are always much more sharper than these 2 margins, so your measurement is more precise. So that is about measuring the size of the follicle with 2D ultrasound. Now, apart from that, you also need to see that the follicle appears nice and high anechoic contents. It has thin walls which are isoechoic to the stroma, and the shape is round or oval. And these are the findings which tell you, yes, this follicle generally appears okay in quality. It is about 24 to 36 hours before the ovulation that you would start seeing a hypoechoic line, and this is a sign that the ovulation may be occurring within next 24 to 36 hours. And sometimes you may also see a tiny solid projection arising from the wall of the follicle, which is probably a cumulus. Why did I say probably a cumulus? Because sometimes it does happen that there may be a small follicle by the side of this larger follicle, and the wall of this follicle may appear like a shelf. So if you rotate the probe, once you see this cumulus-like structure, if you rotate the probe and you see that this solid projection either remains as such or it disappears, if you have changed the plane by chance, it disappears, it may be a cumulus. But if it elongates or if it walks with the rotation of the probe or movement of the probe, it is not a cumulus, it is probably a wall of the neighboring follicle. But there is one thing which is, of course, yes, cumulus is one of the surest signs to tell you that the follicle contains a fertilizable oocyte. But since it is a very tiny structure, you need to zoom the follicle well, and you need to scroll across the follicle in the longitudinal and in the transverse plane, and only then if you see this, you still see this cumulus, you know that it's a cumulus. So therefore, the literature says yes, follicles beyond 15 millimeter are likely to show you cumulus, but if you are using only 2D ultrasound, the chances that you would see the cumulus is only about 30 to 35%, but if you can see a 3D, then the cumulus would be seen in more than about 85% of mature follicles. Since it is not very commonly seen or being able to locate in every mature follicle, therefore, yes, if you see it is a positive sign, but it is not a mandatory sign before you give a trigger. But it is that also which tells you that the ovulation may occur within 24 to 36 hours. It's very important to understand here that many a times you may see a follicle and you will see a crescent-like structure inside, which people say, was it there? I don't know. So if that is there, people say this is a cumulus. This is not a cumulus. Cumulus is a cell mass. It has to be solid. If it's a crescent-like structure, it is only a neighboring follicle. It's only a small follicles by the side of that large follicle, and it is not a cumulus. It is about 6 to 10 hours before ovulation that you would start seeing low-level echogenicities inside the follicle. And it is around the same time that you will also see niche-like triangular lesions or breaks in the wall of the follicle, which is called a rose-bush thorn sign. So low-level internal echogenicities and this niche-like projections tell you that the ovulation is truly impending. Why are these low-level echogenicities seen? Is because You know that the cumulus oophorus complex is secured in the follicular wall under a cell layer. It is just before the ovulation that this cell layer separates and the cumulus is released inside the follicular fluid. When the follicle matures, gradually the follicle has surfaced onto the ovarian surface, and from the surface from where the ovulation is going to occur, that part of the follicular wall bulges a little out of the ovarian wall, and because it bulges out, it gets thinned out. The vessels regress from there, so it also becomes avascular, therefore more fragile. When the follicle is mature, that's when the the fimbria of the tube come and overlie on that part of the ovary. There is ciliary movement which occur in the tube, which leads to negative pressure. It is because of this negative pressure that the fimbrial end, which is covering on the thin part of the follicle, that membrane ruptures and it sucks all the fluid into the tube, along with which the cumulus also goes to the tube. So that is why when we were doing demos, I think twice or thrice did I say that it's not just the tubal patency that is important, it's the tubo-ovarian relationship which is important. And unless the tubes are close to the ovaries, they will not be able to pick up the ovum that is released with the ovulation. But there is something very important that I want to tell you here. I think I will require a mic. I cannot stand and talk. वो hand वाला mic देखो ना, अगर हो सकता है तो please. So, and what is that fact? The fact is that if all the fluid has been taken up by the tube, so if the fimbrial end is well opposed on the anything which is working, so if you see that if the fimbrial end of the tube completely covers onto the ovulation site, no fluid will leak outside. And if no fluid will leak outside, I am confident that the cumulus is inside only. Fertilization is going to occur, or it is likely if everything else is fine. But if there is fluid in the pouch of Douglas, which most of us believe is a sign of ovulation, I am not happy with it, because I would believe that it is possible that if some fluid has leaked out, the ovum might have also leaked out. So very important to understand that free fluid is not, presence of free fluid doesn't tell you anything. Doesn't tell you anything also because there would be free fluid present even in absence of ovulation if the estrogen level is high. That means presence of free fluid doesn't tell you ovulation has occurred. Absence of free fluid doesn't tell you ovulation has not occurred. What does tell me then the ovulation has occurred? The follicle which was growing starts showing internal echogenicities in form of hemorrhagic echogenicities, fishnet appearance, honeycomb appearance, fibrin strands, or it is completely collapsed. One of the two things tells me yes, ovulation has occurred. Yes, so that was just one side talk which I could have avoided, but I thought it is interesting and that's why I told you. So that means that your 2D ultrasound tells you ovulation is going to occur, but it doesn't tell you anything about the quality of the follicle. The quality of the follicle can only be assessed by the Doppler, and the blood flow that has started developing with the dominance of the follicle keeps on increasing and grows to cover at least 2/3 to 3/4 of the follicular circumference. And it is 2 days before ovulation, 48 hours before ovulation, that you will see that the RI of these vessels, they go below 0.5. This is the same time when the final estrogen surge comes, and therefore the fall in the perifollicular RI tells me that there is a final estrogen surge, and it also tells me that the estrogen level is adequate. That also means that the follicle quality is adequate. It is beyond that time that the PSP of the follicle starts rising, and when the PSP of the follicle reaches 10 centimeters per second, this is the time when the LH surge is going to start. That means perifollicular pre-ovulatory PSP correlates with the LH. So if the follicle has vascularity covering at least 2/3, preferably 3/4 of the circumference, and it shows RI of less than 0.5, and it also shows an PSV of more than 10 centimeters per second. Yes, this is the time when, if it is a natural cycle or it is an oral ovulogen cycle, the surge will start. And if I am going to do IUI, I will give a trigger because I need to time the IUI. But if I am not going to do an IUI, if I am not even giving her a timed intercourse, that is when I don't need to do anything. I do a follow-up, and with these parameters, LH surge has to start, and within 2 or 3 days, you will see the ovulation occur. But if it is a gonadotrophin cycle, then it is very important to understand that because you are giving exogenous gonadotrophins, therefore, the endogenous hypothalamo-pituitary ovarian axis, the control of the gonadotrophin, it becomes very lazy. It may start the LH surge, but there's a high possibility that this LH surge may be inadequate or the surge may not occur at all. And therefore, whenever you are giving gonadotrophin, trigger is a must. So why do we need to evaluate these flows? Is because, as I told you earlier, it tells me about the functional maturity. What is that functional maturity? Yes, if I have seen this, the flows on Doppler in the follicles, the perifollicular flow, that means that if I do give a trigger and if I do a pickup, I am going to get oocytes from those follicles. Not only that, even if I have not seen the flow and I do get oocytes, but those oocytes have a high chance of chromosomal abnormalities because of segregation disorders, and that would lead to catastrophic mosaics in the resulting embryos also. Another study also says that if the PSV of the follicle is less than 10 centimeters per second, the chances that you would get grade 1 embryos out of these oocytes is very little. It is therefore that it is very essential to check the RI and the PSV of the follicle in the decision making. I would just as a little sidetracking, I know, but I need to tell you this, and that is this study which I've quoted here is 30 years old, 27 years old. It dates back to 1996. And even that, then, if it is, I mean, the study writes that if the PSV is more than 10 centimeters per second, the chances of pregnancy is as high as 70%. If it is less than 10, it is 40%. If there's no flow at all, it is only 24%. But in this 30 years, we all know that the Doppler sensitivity has increased tremendously. And if that study was done today, I would say that the last sentence would have been only 5 to 7%. So if there's no flow, the chances that you can get a fertile, good quality embryo out of that oocyte is as low as about 5 to 7%, not more than that. Not only that, I also want to request, the director Saab is not here, but I wanted to request him that please plan for a Doppler, because that will improve the results in majority of the people, because you can get a pregnancy with only IUI. You don't need to do IVF in majority of the patients. That is not a help to doctors alone, that's a huge help to the community. So if anybody can, Principal Madam can, please convey my message to the Director Saab to get at least a Doppler. I'm not saying a 3D, 4D machine, but at least a good Doppler that can improve your results significantly. Coming to the next point, and that is, yes, if the vascularity is more naturally, the follicle is producing more estrogen, because more vascularity, more receptors to FSH, more estrogen secretion, it will ultimately lead to a timely LH surge. So if at all you can, so if I said that the vascularity has to cover at least 2/3, preferably 3/4 of the circumference, you either, if you are using only a 2D and a Doppler, you have to switch on the Doppler and then gently scroll across the entire follicle in one plane, in the another plane, so longitudinal plane and the transverse plane, and eyeball and evaluate how much of the follicle is vascularized. Of course, if you have a 3D, you have a boon, you have a luxury, and you can beautifully see this vascularity. But remember, better the vascularity, better is the estrogen secretion, and better is the quality of the follicle. I will not include anything about 3D here because probably it is untimely to do that. But let us go and see this. So this is about the IUI cycle. Now what about the IVF cycles? When it is an IVF cycle, yes, it is true that in IUI cycle, sometimes you may get multiple follicles, but if you follow the baseline score that I'm going to tell you, you will never have multifollicular development. Even with antral follicle count of 45 to 60, we have developed only 1 or 2 follicles in these females, even with gonadotrophin stimulation, following these protocols. So most of the times in IUI, you are not going to develop multiple follicles, but by chance you have produced multiple follicles in IUI, or when you are doing IVF where you opt for multiple follicles, that is when all the follicles, they are compressed by each other. You can see they are all compressed by each other. Because they are compressed by each other, none of the follicle will appear round or oval. If the follicles don't appear round or oval, you cannot take the mean diameter as the correct size assessment for the follicle, isn't it? Say for example, I am talking about this follicle here, okay, this follicle, which is same as this follicle. If I take a longest diameter, it is this diameter. If I take a longest diameter perpendicular to the longest diameter, it is this diameter. But the follicular size is much smaller in all other areas rather than that longest diameter. So I am always going to overestimate the size. Therefore, when you have multiple follicles, that is when this is one place where I would request, if at all, the patients or the people who are doing IVF here, I am sure they may have friends who also have 3D machines. So just for those patients, not for all the patients, for just for those patients, please send the patient to the radiologist or to any of your friends who has a 3D 4D machine, and take a volume of this and get a Sono AVC done. What is Sono AVC? It color codes every follicle, as you can see there. Not only it color codes the follicle, but therefore it identifies every follicle, and then it measures X, Y, Z diameter, mean diameter and volume of every single follicle. Now what is the advantage of all this? To know the correct size of the follicle. Why do I need to know the correct size of the follicle? Because I want to find out, 1, the correct time of the trigger, 2, I want to find out what to give as a trigger, and how to prevent OHSS and how to prevent multiple pregnancies in IUI cycles. So if I say that, the first thing that I want to tell you is, though we usually take mean diameter as the diameter of a decision, we actually are doing wrong. As I told you, the mean diameter in irregular follicles is not going to give you the correct diameter. You have to take this diameter, which is called volume release diameter. What is a volume release diameter? You have the volume of the follicle, which is irregular, make a sphere of the same volume, and the diameter of that is the volume release diameter. That means now you know the correct size of the follicle. And if you see there is, even if you see just the first follicle, there is a difference of 3 millimeters in size. So that makes a huge difference in your decision making, and therefore whenever you have multiple follicles, that is when I would request you and suggest you, for all my friends who are doing IVF, please get a Sono AVC done so that you can make a correct decision of the size of the follicles and the correct decision of the trigger. Yes, it is true that when you are doing an IVF cycle, that is when you would always wait for at least 3 follicles between 16 and 18 millimeters before you give a trigger. But we all know who are doing IVF that n number of times it may happen that you have given a trigger, you do a pickup and there's nothing inside. Why is there nothing inside? Not that the follicles are truly empty, because the final meiosis has not been triggered, and it is because of that the oocytes don't separate. The cumulus doesn't separate out of it, and you don't get follicles. Why would that happen? Because the LH has not acted on it. Why is the LH not acted? Because you have not checked the flows. You do not know what is the LH receptors. You do not know what the LH receptors have developed or not. Therefore, even if you are doing an IVF, check for flow in at least 3 follicles on both the sides. And if those have flows, you can give a trigger and you will never have an empty follicle syndrome. And I can tell you that out of my experience, it's been since 1999 that I'm using Doppler. And since then, I have not had even one case, and I can swear on that, not even one case of empty follicle syndrome. So this is something very, very important to understand. Look at the flows for at least 3 follicles on both the sides before you give a trigger, even in your IVF cycles. Okay, so that is about loops. What do we mean loops? We will talk about that. We will talk about that. It will come later. In the course of time, it will come. So, you must always check that there is flow, and after that you give a trigger and you would have excellent flows. So that was just about the size of the follicle. Now, I was going to tell you about what should you give as a trigger. This is important both for your IUI and your IVF cycles. We know that when we use gonadotrophins, one fear is OHSS and the second fear is multiple pregnancies, especially when you are doing IUIs. This can be prevented, as you know, by agonist trigger, which has become very popular now. Agonist trigger. We are talking just about IUI first, ma'am, so that's why I didn't say the antagonist cycle. So we will talk about both one after the other. So if I am doing IUI, my fear is 1, multiple pregnancy, and 2, it is OHSS. What is the reason of OHSS? We say that HCG is the reason why OHSS occurs. And why is that so? Because when you give an HCG, there is a long surge which lasts about 48 to 52 hours, unlike the natural surge, which is about 24 hours. So what? What happens is that the follicles which are functionally mature, which have good blood flows and adequate LH receptors, with the surge, they rupture and they form corpus luteum. Corpus lutea are not a cause of VEGF secretion, which is a culprit for OHSS development. The follicles which are suboptimally mature, which are say 15, 16, 17, 18 millimeters in size but have inadequate flow. Because they have inadequate flow, that means they don't perceive the LH fully, and therefore they go into LUF. They don't rupture, they go into LUF, and it is those follicles also. LUF is also not responsible for VEGF secretion. But the follicles which are between 11 and 14 millimeters, medium sized follicles, these follicles, they share FSH and LH receptors. Because they share FSH and LH receptors, when the LH surge comes, that is also felt as FSH, and their follicles keep on growing. Because HCG has a long surge, or the medium sized follicles which come in that range during that entire 48 hours, they all keep on growing. They keep on growing, but once the LH falls after the surge, they don't get luteinized. So they remain as growing, of course their growth rate decreases, but they still remain as growing follicles, and it is these follicles which secrete VEGF, and it is these follicles which are responsible for OHSS. That means that if you have more follicles between 11 and 14 millimeters, apart from whatever mature follicles, that is when you don't want to give HCG. Okay. Agonist has an advantage because it has a short surge, it has only 4 hours of rising limb, so only those follicles which are mature we will rupture, or only 1 or 2 follicles which are between 11 and 14, they will remain as growing follicles, and that would not lead to OHSS. So that means that if I am doing an IUI cycle, if I have more than 6 follicles of between 11 and 14, whatever the number of larger follicles, I will not give any HCG at all. If the number of follicles between 11 and 14 are between 3 and 6, I would give low dose HCG, which is called a dual trigger, where you give agonist full dose and you give only 1500 international units of HCG. Why do I want to put this 1500 of HCG? Because
agonist only trigger has a very high chance of luteal phase defect. So to prevent that, I give that 1500. Moreover, in some studies, it has also been raised a doubt that with agonist alone, the final meiosis may not start, and that is also one reason why we would want to support it with a small dose of HCG. But if the number of follicles between 11 and 14 are less than 3, I don't mind giving even full dose HCG, not a problem, and that is a time-tested medicine as a surrogate surge. But if I'm doing an IVF, I will give no HCG if the number of follicles between 11 and 14 are more than 8. I will give low dose HCG if the number of follicles between 11 and 14 are between 4 and 8. And I will give full dose HCG if the number of follicles between 11 and 14 are less than 4. In IVF, though you are going to aspirate every single follicle and make a rule to actually aspirate every follicle up to 10 millimeters in size, because there are studies which have shown that all the follicles up to 10 millimeter in size can give you fertilizable oocytes. You don't only get more number of fertilizable oocytes, but you would also prevent the risk of OHSS because you have aspirated them all. There are no growing follicles, they're all only corpus luteum. The second fear is multiple pregnancy in your IUI cycles. Now, if that is a fear, multiple pregnancy occur because multiple follicles may rupture. And if you give an HCG trigger, when there are multiple follicles between 17, 18, so about 17, 18, 19 millimeters in size with good flows, yes, that is when multiple follicles will rupture and multiple pregnancy can occur. But it is essential that you check the vascularity. If you have truly suboptimally follicles between about 3 to 4, apart from mature follicles, that's when don't give any HCG at all, because you want only the mature follicles to rupture. Give only agonist. If you have just 1 or 2 follicles which are suboptimally mature and 1 mature follicle, that is when you can give a low dose HCG, not a problem. But if it is only mature follicles and no suboptimally mature follicles, you can give full dose HCG even if there are 2 or 3 after checking the flow, because all of them will not be the same maturity and the same quality. So that is why you need to do a sono AVC and find out the size of the follicle, which tells you also about the time of trigger and the type of trigger. And you also know that there are studies which have shown that it also depends on the medium sized follicles. There is a study, if I'm not wrong, which has shown, just let me show you there, tells you that all the follicles, if the number of follicles are larger than 11 millimeter or more than 25, you should not give HCG at all. Now coming to the endometrial assessment. The endometrium is nothing but, as we were talking with the live demos, it is nothing but a receptor organ to estrogen and progesterone. So if there is no estrogen, it is not going to grow. If there is no progesterone, it is not going to get luteinized or not turn into secretory phase. The estrogen secretion starts with the dominance of the follicle, because we know that with the granulosa cells, if you are all tired at any point of time or you need a small refreshment, just let me know. We will stop for 2 minutes and we can start again, okay? No, I'm okay. I don't want. Yeah, we are fine. Okay. So the follicle, as soon as it grows to dominance, that means it gets receptive to FSH, the granulosa cells, they start secreting estrogen. As early as about day 6 of the cycle, the endometrium starts getting multilayered. In the mid-proliferative phase, the normal endometrial growth rate is 1 to 2 millimeters a day, and it is in the late proliferative phase that it decreases and becomes 0.5 millimeters a day. Now, that growth of the follicles, that growth of the endometrium, as it grows, it is these 2 side lines, naturally they are going to separate. As they separate, there is a space created, so-called space, evident space, it's not a space. That's where you see hypoechoic or anechoic areas in between the lines. So it's a multi-layered endometrium with hypoechoic, severely hypoechoic or anechoic area between the lines, and that is what is called a grade B endometrium. That is usually found in presence of 1 or 2 mature follicles. That means when the estradiol levels are approximately between 100, 150 to 300, 400 picogram per ml. But when there are more follicles, 3, 4, 5, 6 follicles, when the estrogen level is higher, that is when gradually echogenicities start developing between the lines. But these echogenicities are not more than that of the normal myometrium, and the triple layer pattern is still maintained, and this is called a grade A endometrium. But when there are truly supraphysiological levels of estrogen, which means that the estradiol levels are more than about 1000 picogram per ml, which happens with multifollicular development, or may sometimes also happen with only bi or a trifollicular development with PCO patients. That is when you would see that the endometrium loses its multilayered pattern, and it becomes isoechoic to the myometrium. As long as the endometrium is isoechoic to the myometrium, it is not a progesterone exposed myometrium, it is pure estrogen dominated endometrium, and that all the 3 endometria are good for implantation provided the vascularity is good. That means the morphology of the endometrium does not tell me anything about the receptivity of the endometrium. Why should I document it at all? Is because it indirectly tells me about the follicular size. Why do I need to know about indirectly know about the follicular, it tells me indirectly about the follicular maturity. Why do I indirectly need to evaluate the follicular maturity? I'm going to see the blood flows of the follicle. But with the Doppler, Doppler technology has a limitation, and that is it does not have penetration. Its penetration is very low. Therefore, if you have an ovary which is lying posterior to the uterus, or you have an ovary which is lying deep, even if there is a follicle, even if there is a flow, if you put on a Doppler, you will not see that flow. So it is in these cases that you can evaluate the endometrium. If the endometrium shows a good morphology, if you see that the endometrium is also growing at a normal rate, if you also see that the endometrial vascularity is developing, if the cervical mucus is seen, and if the cervical glands show hyperechogenicity, these are the signs which tell me, yes, estrogen is present. And it just doesn't tell me that the estrogen is present. It also tells me the estrogen receptor development is normal, and the estrogen is not only produced, but it is also acting on the endometrium. That means it is giving you one step more information than what your blood test would say. The blood test would say estrogen is secreted, which I know from the follicular flow. But if I'm looking at the endometrial flow, if I'm looking at the growth, I'm looking at the morphology of the endometrium, it tells me also that this estrogen is working. Say for example, therefore, I have say 4 follicles, 3 or 4 follicles between 16 and 18, and I still have only grade B endometrium. I know the estrogen levels are not good. Either none of the follicles are good, or maybe one follicle is good, not all. But if I am seeing a grade A endometrium with that, I am almost sure that mostly all the 4 follicles are going to be good in quality. So that's how it indirectly tells me about the quality of the follicles. It is grade C endometrium. So it is very important therefore to check the vascularity, and the vascularity in the endometrium starts developing along with the follicular vascularity, which is about 48 to 72 hours before ovulation. And the vascularity, if it is so important, we must correctly grade the vascularity. The Applebaum score talks about myometrial vascularity. It may sometimes also talk about subendometrial vascularity, but the days are gone we talk about subendometrial vascularity. The Doppler parameters have improved so much, the Doppler technology has improved so much now that we are talking about intraendometrial flow and not about the subendometrial flow. And therefore, it is essential to confirm that the vascularity is reaching the inner layers of the endometrium, which is called zone 3 and zone 4. When the blood vessels are reaching only the endomyojunction, it is zone 1 vascularity. When it is touching the outer hyperechoic line, it is zone 2 vascularity. When it is coming to the intervening area, it is zone 3 vascularity. And when it is touching the central line, it is zone 4 vascularity. So it is zone 3 and zone 4 vascularity which is essential. But if 1 or 2 vessels are reaching there, will it supply sufficient area for the embryo to implant? No. Therefore, there should be at least 5 millimeter square area which is vascularized. Or to make it simple, there should be at least 5 vessels from both the sides which are closely placed to each other, which are reaching the inner layers of the endometrium. That tells me yes, about 5 millimeter square area is vascularized, and then these vessels have to have an RI of less than 0.6, and that would tell me yes, this is sufficient vascularity in the endometrium. Why is that essential? Because there are literature evidences which says that if the vascularity is less than 5 millimeter, the chances of conception are very less. If there is no intraendometrial or subendometrial flow, there is that is a predictor of failure of implantation. If the endometrial and the subendometrial flow is present, it is a positive prognostic marker not only for the conception but for the ongoing pregnancy. And if the vascularity is not there, then there is 50% chance of miscarriage. Therefore, these parameters are very essential to be achieved before you give a trigger in your IUI cycle, before you give a trigger in your fresh transfer IVF cycle, and before you start progesterone for your frozen transfer cycles. If I say so, as I was showing you with the live demos, it is very essential to master how the endometrial vascularity is to be picked up. Of course, it is not a big skill, but it is important to understand which instance to pick up to assess the follicular, assess the endometrial vascularity. Remember that every spiral vessel does not get filled up in every cardiac cycle. Therefore, and this is a very low velocity flow, so you have to wait for the machine to get sensitized to it. So zoom the image well so that you are seeing the endometrium filling up at least 1/2 of the screen. Switch on the Doppler. The box size should be so adjusted that it includes the entire length of the endometrium but doesn't take a large strip of the myometrium, because if it takes a thick strip of the myometrium on both the sides, the myometrium vascularity gives you a false impression that the endovascularity is there in the endometrium. So it has to include the entire endometrium, and then switch on the Doppler and hold the probe there steadily for a little while. You will gradually see, even if you are seeing here, you will gradually see the vessels coming up, and the vessels will not be present in every cardiac cycle. So pick up an instance when you are seeing maximum vessels, and then, so to evaluate as to how much of the endometrium is vascularized, and then pick up any one vessel which is inside the endometrium. Measure the flow in the vessels inside the endometrium, not in the subendometrium, and it should have an RI of less than 0.6, and that tells you yes, there is sufficient vascularity in the endometrium. But it is, and there are studies which have shown that if this vascularity is not present, the chances of, when the vascularity is not present in zone 3 and 4, the chances of pregnancy are less and the abortion rate is very high, whereas when the vascularity is present in zone 3 and 4, not only the pregnancy rates are more, but the abortion rates are significantly lower. There are a few people who would tell me that even if the vascularity was not there, I got a pregnancy in this patient, I got a pregnancy in that patient. I don't disagree to this at all, because when we are talking of conception, it is a combined function of endometrium and embryo. So if the embryo is excellent, even if you have less vascularity, it will go and implant. But if the embryo is not good, you need an excellent endometrium to get a pregnancy. And even with all our highly technological gadgets, time-lapse camera and this and that, you can still not evaluate the embryo quality correctly. So why not check the endometrium well so that you can improve your pregnancy rates to the best possible. If the endometrium appears persistently thin, in these cases, it is good to take an endometrial volume. And if the endometrial volume is at least 2 cc with good vascularity, the chances of pregnancy are good even with an endometrial thickness of only 6 or 7 millimeters. But if the volume is less than 2 cc, the chances of pregnancy are very, very less. So if you are not satisfied with the endometrial thickness, again, that does require a 3D, I do agree, but take a little bit of chance. The patient may be waiting with the frozen embryos for 2, 3, 4 cycles. It is worth to send that patient to a radiologist and get a vocal done for the endometrium when you feel the endometrium is maximum in thickness. Apart from this, you also need to check the uterine artery Doppler, and the uterine artery Doppler must show a PI. We did today. PI should be less than 3.2. That tells you it is adequate estrogen receptor development, and it is adequate time to, it is an optimal time to give a trigger. So that is the endometrial and the follicular behavior till the time of trigger. After that, what happens? I told you that the PSV correlates with the LH. So with the low LH, with the low RI, that means adequate estrogen, if the PSV of the follicle is high, we know that the LH surge as it starts, the initial 6-7 hours is a slow rise in LH, and then there is a sudden rise in the LH levels. And therefore, at the start of the LH surge, the PSV is 10, which rises to as much as about 45 centimeters per second just an hour before the rupture. That means that if I am doing a pre-ovulatory scan, and if I see that the RI of the follicle is less than 0.5, but the PSV is not 10, it is 15, 20, 25, 30. That is when the surge has started already, and I am not 36 to 42 hours away from the ovulation. The ovulation is going to occur within a shorter time. And remember that, yes, it is true that after the ovulation, the ovum does survive for 16 to 18 hours, but its fertilization capacity significantly decreases every hour. And therefore, if the IUI is planned when the ovulation is expected to occur, the chances of pregnancy are maximum. Therefore, I will request you, if you are doing IUI cycles, please don't confirm ovulation on your scan and then do an IUI, because if you confirm the ovulation on IUI, you do not truly know how many hours before the ovulation has occurred. And even if you are working the fastest, even if you have in-house facilities, you tell the patient, collect the semen, process it, and put it. So do an IUI, it would take at least 2 hours. You are decreasing the chances of pregnancy. So always predict when the ovulation is going to occur. With what? Of course, your Doppler parameters. You know that the RI of the follicle is going to fall 48 hours before ovulation. You know that the internal echogenicities are going to occur 24 to 36 hours before ovulation. You know that the endometrial vascularity is going to start within 48 to 72 hours. You also know that the PSV of the follicle, which was 10 at the beginning, is going to start rising. And therefore, if it is higher PSV, the ovulation is going to occur. That means you have probably all the parameters which are going to tell you that what time the ovulation is going to occur. And if I say so, there are a lot of literature evidences. Increased vascularity of the follicle and coincident rise in the blood velocity are the signs of impending ovulation. Increase in PSV starts about 29 hours before ovulation and continues for 72 hours. And a marked increase in the PSV around the follicle in the presence of a relatively constant RI could be a sign of follicular maturity. In short, forget about those evidences. We don't need to remember that. But what is those were just to assure you what I'm saying is not a dream. It is a fact, and it is an evidence. But what did we see? It was long years back that we did one study where all the follicles which were larger than which had a PSV of more than 15 centimeters per second, we randomly divided them into single IUI, 36 to 38 hours, double IUI, 12 to 14 and 36 to 38 hours. if you look at these charts, which are the result sheet of that study, the red bars are the pregnancies with single IUI, 36 to 38 hours, and the yellow bars are the pregnancies with double IUI, 12 to 14 and 36 to 38 hours. And if you see there, it is the PSV of the follicle written. You can see that beyond 20, as the follicular, as the PSV is increasing, the yellow bars are getting taller, whatever is the protocol. That means when the PSV is high, it is the early IUI which is helping us to give us results. Not only that, very striking is this decrease in the pregnancy rate with the single IUIs as the PSV is rising. That means that if you are doing the IUI at the same time with whatever PSV is there, you might be missing the, you will not get the pregnancies in those patients who have higher PSV. You get my point? That means many a times it happens, you have the same size follicle, when you give a trigger, some patients will conceive and some will keep on not conceiving. That is when you have not seen the Dopplers. If you have seen the Dopplers and then you have given a trigger, that's when you know that what is the PSV and therefore what time you should do an IUI. So yes, it is true that even the Cochrane study says that in every patient double IUI doesn't help. Yes, I agree, but it is in this small subgroup of patients because that study doesn't include Doppler. It is definitely in the small subgroup where the PSV is high, the early IUI helps. And the practice that we follow is when the PSV of the follicle pre-ovulatory, pre-trigger PSV is 10 to 15, we do single IUI 36 to 38 hours. When the perifollicular PSV is between 15 and 25, we will do 2 IUIs 12 to 14 and 36 to 38 hours. And when the perifollicular PSV is more than 25, we will do only 1 IUI 12 to 14 hours. And that maintains our pregnancy rates of IUI as 80 to 85% in 6 cycles. So it is very important that you do a good Doppler monitoring and then give a trigger. That is why I requested most of the patients will conceive with IUI, master Dopplers, and you will be kings of your infertility practices. So on one hand, when increasing PSV tells us that the surge is likely to occur. On the other hand, if you see that the PSV remains steady or falls, but the RI starts increasing, that is when this follicle is going to go into LUF. So why is that important to us? We are monitoring a cycle. We are waiting for the follicular flow is good and we are waiting for the endometrial flow to come, or the follicular RI is good and we are waiting for the PSV to rise. It is during this phase, this is the time when you are calling the patient every day. Now if you see that the RI which had gone below 0.5 now starts increasing, so that is the last day that you can give a trigger. If you wait for one more day, the luteinization has already occurred. So that rise in PSV is telling you that, that rise in RI tells you that the LH has started. Okay. Now, on one side, when the PSV of the follicle rises, as the surge starts, on the other hand, with the start of the surge, what happens is that the estrogen level falls and the progesterone takes about 3 to 4 days to rise. It starts rising before ovulation, but to reach a plateau, it takes 4 to 5 days. That means there is a period where estrogen and progesterone both are low. If estrogen and progesterone both are low, what happens? Because estrogen falls, the vascularity of the endometrium decreases. Because the progesterone starts, the initial compacting effect and the endometrial thickness also decreases by about 0.5 millimeters. Because of that same compacting effect, the outer margin of the endometrium starts getting fluffier. As compared to that sharp line that we are seeing, it starts getting fluffier. And because the endometrial vascularity decreases, therefore, even the uterine artery PI increases. So, decrease in endometrial thickness, decrease in endometrial vascularity, fluffiness of the outer layer of the endometrium, and the increase in the uterine artery PI are the 4 points which tell me the effect of early progesterone has started. If you are seeing this changes along with a mature follicle and a high PSV, that means everything is in synchrony. I do an earlier IUI and everything is perfect. But if I see this changes in the uterus and the endometrium, with an immature follicle, that means it is an early surge. And if it is an early surge, that is when I have to give antagonist in the next cycle. This cycle it is not going to help because the antagonist helps only when it is started before the LH receptors develop. The LH receptors usually start developing, as we know, 14 millimeter size and beyond. So you can add antagonist in the next cycle, or by chance if it has resulted from high level of estrogen because of multifollicular development, only if you control the number of follicles developing, you can still prevent that premature LH surge. And if you are seeing these signs and you are not seeing any follicle at all, that means you have missed the ovulation. Do a detailed trigger, because the vascularity is going to decrease and the thickness is also going to decrease during that period. So that just answering a few of your questions, FAQs, which are very commonly asked. What do I do if I am not getting the blood flows? Until when do I wait? We can wait for the follicular flows to develop till the follicular size of 24 millimeters at least, whether it is a gonadotrophin cycle or it is a CC cycle. Though in CC cycles it is commonly seen that you would start seeing the flows only late in the proliferative phase when the follicle reaches 23, 24 millimeters or sometimes 22 millimeters in size, because when you give CC there is more fluid imbibition in the follicle size increases but the maturity doesn't, and therefore the flow develops late. It is because the flow develops late, it is because it is because the follicular maturity is achieved late, therefore the endometrium also develops late. And it has been shown in the studies also, it has been proved in the studies also that in the CC cycles, it is only in the late proliferative phase, suddenly in 2 days the follicle will increase 2 to 4 millimeters. So it is very important that you wait for the follicular maturity to be achieved. Now if the follicle, so what happens generally is the follicle has reached 18, 19, 20 millimeters, you are worried the follicle is going to rupture, so you give a trigger. But remember that if the flows are not there, that means the LH surge is not going to start, that follicle is not going to rupture. So for the inadequate follicular flows, you can wait till the follicular flows appear. But if with good follicular flows, you still have weak endometrial flows and you're waiting for the endometrial flows to come up, you cannot wait beyond a point, because yes, it is true that the endometrial flows are not good, you are not happy, you are not going to be, the findings are not optimal before the trigger, but if the follicular flows have developed, the surge is going to occur and you cannot wait for that. What we do is, we explain the patients this in detail and then we give them an option. Look, the chances of pregnancy appear to be a little less because the flows are not optimal. You can either take a trigger and go for IUI, you can take a trigger and take a natural intercourse, or we can just keep on seeing every day, whichever day the follicle is ruptured and you have not had an intercourse, we'll do an IUI. Yes, but you have to explain this to the patient, and this is very important. Non-rupture of the follicle is not possible if you have seen the flows and then given a trigger. It is out of question. The only possibility is that the LH might have not, the trigger injection would not be a good quality when the cold chain is not maintained or whatever, or by chance the dose has fallen short. This often happens when you have given only 5,000 IU. So remember, whenever you are using urinary products and you are giving HCG, don't give less than 10,000. There are many companies who, because of the legal permissions, they, instead of your 5,000, it would be only 3,500. So 10,000 may actually be only 7,500. That's why we also request people that if you are using as a trigger, instead of using urinary product, a little costlier, but it is a sure shot, use recombinant HCG, which is equivalent to only 6,500 IU. So lesser chance of OHSS also and a better result. Sorry? Receptor polymorphism, that is when you have to then go for a dual trigger. But still it doesn't happen. Sorry? That's what I said, recombinant HCG. Okay, now I think, I don't know whether it's available here or not, but in India now, highly purified urinary is available, which is just 7,500. So that is also a good option if you want. Thin endometrium is a diagnosis only in presence of a good follicle. If the follicle is not good, the diagnosis is bad follicle and not a thin endometrium. But if it is truly a thin endometrium, look at the junctional zone. If the junctional zone is irregular, that is when you should give, you should suspect either adenomyosis or chronic endometritis and accordingly treat it. But if it is intact junctional zone, that means it may be either Escherman or it may be a hyperprolactinemia, which is very common with CC cycles. Every CC cycle does not give a bad endometrium because of only estrogen receptor blocking. There are some patients in whom there are night spikes of hyperprolactinemia. Because there are night spikes, it would not come in your daily blood tests, and they would only show good quality follicle but still bad endometrium with no other endometrial pathology seen, like we saw in one patient today. You said the follicle was good but the endometrium was thin. So in those cases, you can give them, if it is a CC cycle, this is a possibility, and you can give them bromocriptine for the first half of the cycle. And if the endometrium grows, that means yes, this was the cause. And if not, you will not. So if the endometrium grows, you can continue the same therapy for at least 3 cycles. But if it doesn't, that means that is not the cause. So that is probably all about the pre-trigger. If we want to, we can take a break here and finish up with a lunch. Do we want to? Sorry, but I will go on and on, not knowing where to stop.
At least break some for some time. Thank you, madam.